So once again, a newer topic, which is very important concerning with perio, acute gingival infections. Under acute gingival infections, according to Kerensa, just given importance to three main lesions. One is a bacterial infection, another one is a viral infection, and a fungal infection also. But we are concerned about three major one. But one is acute necrotizing ulcerative gingivitis, acute herpetic gingivostomatitis, and pericornitis and gingival abscess. So first one is acute necrotizing ulcerative gingivitis. It is otherwise known as ANAC. It has got different synonyms. One is trench mouth, another one is ulcerative gingivitis, then Vincent's stomatitis, then Paul Vincent stomatitis. These are different names of the necrotizing ulcerative gingivitis. When we talk about ANAC, ANAC has been described in the World Workshop in clinical periodontology as rapidly destructive, non-communicable gingival infection of complex etiology. Prevalence: it is primarily a disease of young adults in the age group of 18 to 30 years. Epidemiology frequently occurs in epidemic pattern, seeping through groups or persons in close contact. It was especially apparent during World War I among the soldiers. So it is known as trench mouth. It's been classified into acute, subacute, and recurrent. These are the three main classifications of ANAC. When you talk about the clinical features of ANAC, it has got a history of sudden onset, sometimes following an episode of debilitating or a debilitating disease or an acute respiratory tract infection, maybe a change in the living habit of the person. And sometimes underlying psychological stress is also being noted. Sometimes the patient also gives an history of soreness and bleeding resulting from pressure in involved area during eating and toothbrushing. Now we want to talk about oral signs and symptoms. The typical signs of ANAC, it's a punched out crater-like depression at the crest of interdental papilla, extending to margin gingiva. That is one of the typical character of the ANAC. So I want to give stress on that. It's a crater which is of a punched out nature at the crest of the interdental papillae. First, the lesion starts at that point. Then it extends into the margin gingiva. Always the surface of the crater is covered by a grayish pseudomembrane, or otherwise you call it as slough. It is, the color looks grayish white. Crater is demarcated from the main, demarcated from the remainder of the gingiva by a linear erythema. So you can fully visualize the lesion. The center there is a white slough, and there is a linear erythema around, which differentiate it from the surrounding normal tissue. Sometimes the cases may devoid of pseudomembrane also. So only you'll see some red, shiny, and hemorrhagic area. Progressively, it destroys the gingival and periodontal tissue. You call it as recurrent or sometimes it may change into necrotizing ulcerative periodontitis or NUP. Gingival hemorrhage, pronounced bleeding on slightest provocation. That is another feature of NUP. Usually, sometimes there will be a fetid odor and an increased salivation because of the necrosis of the tissue. Usually, it is rare in pedunculous mouth. Then, now we talked about signs. Now we are coming into the symptoms. Because it's a acute lesion, it is extremely sensitive to touch. Patients have a solid pain, constant radiating gnawing pain, intensified while eating spicy or hot food, and even chewing. Because of the pasty saliva, there will be a metallic foul taste. And there will be increased salivation, which is the saliva is of a pasty in nature. There will be a combined systemic problem also, because it's a systemic disease. So naturally, all the symptoms and signs of systemic problems is also been seen in such group of patients. Especially, there is local lymphadenopathy and slight increase in temperature, mild and moderate rise in temperature can also be seen in some cases. In severe cases, high fever, increased pulse rate, leukocytosis, loss of appetite, generalized lassitude. In children, insomnia, constipation, GIT disturbances, headache, and mental depression. In rare cases, because of the necrotizing nature of this disease, if you didn't treat it or you didn't mind it, it may end up in normal. And fusospirochetal meningitis, fatal brain abscesses, and pulmonary infections and toxemia. A few about the microbiology. As we know that this lesion or infection is caused by a combination of fusospirochetal infection. It's the main culprit of the organism in Borrelia vincenti. It's a fusospirochete. So any fusospirochetal infections will be fatal and it's not being treated properly. Now I'm going to talk about the clinical cause of the disease. There is a progressive destruction of periodontium and denudation of roots. Sometimes it may show as a spontaneous remission and exacerbation. That's the nature of the disease. Body itself limits the disease, but sometimes it shows an exacerbation. When you talk about histopathology or microscopy, lesion appears as non-specific, acute, necrotizing inflammation at gingival margin involving stratified squamous epithelium and the underlying connective tissue. In surface epithelium, which is destroyed and replaced by pseudomembranous mesh. Usually it is a fibrin mesh. Necrotizing epithelial cells, PMNS, and various types of microorganisms can be seen in the lesion. This zone appears as a surface of pseudomembrane. These are about the microscopic nature of the lesion. When you take a biopsy from the papilla, you will find the tip of the papilla and the tissue approaching the coal have been destroyed by ulceration. The oral epithelium is relatively intact. In deeper layers of biopsy, observe the red-stained intact collagen, while beneath the decimated papilla, collagen is largely obliterated. When you talk about the connective tissue layer of the lesion, there will be a marked hyperemia with numerous engorged capillaries and a dense infiltration of PMNS. That's a typical feature of an infected lesion. The acutely inflamed hyperemic zone appears clinically as linear erythema beneath the surface of pseudomembrane. There is a gradual blend of the epithelium and the connective tissue from the involved gingiva to the necrotic lesion. When you talk about the role of bacteria, there is, when you view under light and electron microscopic studies, exudate on the surface of the necrotic lesion contains cocci, fusiform bacilli, and spirochetes. The layer between necrotic and living tissue, enormous number of fusiform bacteria and spirochetes with leukocytes and fibrin involved. Sometimes it has been seen invaded by different group of organisms also. This spectral microscopy divides into zone 1, zone 2, zone 3, and zone 4. That most superficial consists of varied small bacteria and small and large spirochetes. That is zone 1. When you talk about, this is bacteria zone. When you talk about the zone 2, which is neutrophil rich zone, contains leukocytes, especially neutrophils, with bacteria and many spirochetes of various types between the leukocytes. And the zone 3, which is necrotic zone. Disintegrated tissue cells, fibrillar materials, remnants of cells, fibers, intermediate and large spirochetes, and other bacteria you can see. In zone 4, the zone of spirochetal infiltration, you will find well-preserved tissue infiltrated with intermediated and large spirochete without other organism. This is the microscopic picture of the regarding the organism. Now coming into the habit, a few words about the habit of the patients. If the patient is having a habit of smoking, as we know that smoking has got a very deleterious effect on the body, especially in healing. So in this case also, smoking has got a negative effect. Local and systemic catecholamines released in response to nicotine from smoking causes a reduction in gingival papillary blood flow. So any tissue wants to heal, it needs a rich blood supply. So there is a hampering in the blood flow. So because of the hampering in the blood flow, there will be a localized ischemia in periodontal tissue. So there will be a deficient post-defense mechanism, which lead into necrosis. When you talk about the clinical cause of the disease, Pinbar one stay, erosion of tip of the interpapilla, leading to lesion extending to margin gingiva, which potentially causes the loss of the papillae, attached gingiva, and exposure of the bone. These are the stages where Pinbar classified. And when we talk about the etiology, that is very, very important in case of ANAC. There are different etiology. The specific etiology of the ANAC has not been established, but the role of bacteria is confirmed. Paul and Vincent produced the concept that ANAC is caused by specific bacteria, namely fusiform bacillus and spirochetal organism. Others like Bacteroides melangogenicus, P. intermedia, Fusobacterium treponema, and Actinomyces odontolyticus, and Salmonella species. In systemic predisposing factors, like one is systemic diseases, another one is nutrition deficiency, and emotional stress, and hormonal imbalance. When you talk about systemic disease involving depression, infection, and or number of leukocytes and immune suppression. Example, malignancy, systemic lupus erythematosus, agranulocytosis is usually seen in AIDS, and viral infections like cytomegalovirus infection. In nutrition deficiency, patient is of a very poor socioeconomic status, with lack of vitamins, lack of food, as a conditioning effect on bacterial pathogenicity, malnutrition, especially vitamin A, ascorbic acid of vitamin C, and implicated in etiology of ANAC. Then emotional stress. There is no direct correlation, but there is a correlation. I'll tell you. Stress increase adenocortical activity, inability to control indigenous bacteria, increase epinephrine levels, localized ischemia of gingiva, psychiatric disturbances plus stress, lead to activation of the HPA axis, and increased serum and urine cortisol levels, and depression of lymphocyte and PMNS function. Now we are coming into the diagnosis. Interproximal necrosis and ulceration is a typical feature. Painful gingiva, bleeding on spontaneous provocation, pseudomembrane slough, and fever, malaise, and lymphadenopathy and a fetid odor. But you have to differentiate from the other diseases: streptococcal gingivostomatitis, gonococcal stomatitis, agranulocytosis, Vincent's angina, Anagin HIV, acute herpetic gingivostomatitis, discriminative gingivitis, sometimes in chronic destructive periodontitis, sometimes very rarely in a secondary stage of syphilis. So we are coming into the treatment aspect of the acute necrotizing ulcerative gingivitis. One is surely elevation of the pain, elevation of the fever and malaise, correction of systemic conditions, and contribute to the initiation of progression of the gingival changes. First one is you have to differentiate into first visits, in different visits. Patient's background you have to take as history, recent illness, living condition, dietary background, type of employment, and hours of rest, mental stress, etc., etc. Then patient has to be observed for his general appearance, apparent nutritional status, and responsiveness. In first visit, you start with the removal of the pseudomembrane and removal of the superficial calculus. Use of hydrogen peroxide in a 0.12%. Very slowly, you have to irrigate with the hydrogen peroxide, and 0.12% chlorhexidine twice a daily is being used. Patient's cystic symptoms needs antimicrobial therapy, penicillins or erythromycins. Sometimes you can start with metronidazole also. Avoid habits like tobacco smoking, etc., etc. So in the second visit, after 2 or 3 days, scaling is performed if there is poor oral hygiene. Almost the same instructions for the patient. Third visit, that is beyond 2-3 days, maybe 4 days or 5th day, patient should mostly of symptom free. Scaling and root planing, if needed, you can do. Hydrogen peroxide mouthwash is recommended. Subsequent visit, tooth surface in the involved areas are scaled and smoothened, and most probably you will find a thorough healed area. So this is about a neck. When is it untreated, it may end up in a necrotizing ulcerative periodontitis. That's a different entity, and I will explain that in a different class, because these are more of a periodontal nature rather than a gingival nature. Now we are coming into the other lesion, which is, as I mentioned previously, primary herpetic gingivostomatitis. Primary herpetic gingivostomatitis causes virus, which is herpes simplex virus, that is type 1. Age usually at infants and children younger than 6 years. Both sex equally affected. 90% of these primary HSV infections are subclinical. Patient may have non-specific symptoms such as cervical lymphadenopathy, malaise, low-grade fever, and lesions referred to primary herpetic gingivitis usually affect 5% of the gingiva. After the primary infection of HSV is found, is residing in the trigeminal ganglion in latent form. Various stimulus like fever, stress, sunlight, etc., can lead to the activation of the secondary HSV infection. Usually it occurs as herpes labialis, herpes genitalis, ocular herpes, and herpes encephalitis. Clinical features: diffuse erythematous, shiny involvement of gingiva and oral mucosa, edema and gingival bleeding. Initial stage is multiple discrete superficial ulcers throughout the oral cavity on both mobile mucosa and mucosa attached to the bone. You can see everywhere. After 24 hours, these vesicles usually ruptures and form a painful ulcer with a red elevated halo-like margin and depressed yellow color with a central portion. Cause of disease usually of 7 to 10 days. But the diffuse enlargement and edema may persist for several other days after the ulceration have been healed. Usually no scarring. Oral symptoms: soreness of oral cavity, pain, ruptured vesicles, sensitive to touch and thermal changes and food, etc. Extraordinary signs and symptoms are cervical adenitis, fever, generalized malaise. History of the disease: is a recent acute infection. History of febrile disease during or before HSV infection. Stress and strain and anxiety. History of exposure to herpetic infection or history of mononucleosis. Histopathology: ballooning degeneration of the epithelium, acanthosis, nuclear clearing and nuclear enlargement, you call it as Zang cells, presence of multinucleated giant cells with intracellular edema, intraepithelial vesicles. Fibropurulent exudates macy. Due to rupture of the vesicle, discrete ulceratic lesions can be seen. The diagnosis can be made on clinical history and presentation. You can take cytological smears of intact or recently broken vesicles, demonstrate epithelial giant cells. When you talk about differential diagnosis, acute necrotizing ulcerative gingivitis, you can take into consideration. Erythema multiforme, Stevens-Jones syndrome, bullous lichen planus, discriminative gingivitis, and recurrent aphthous stomatitis. So these are the differential diagnosis of the lesion. When you're coming into the treatment, symptomatic treatment, rinsing with a 50 to is a half suspension of Benadryl captoate and or viscous lidocaine before and after meals. That is usually to soothe the tract. That's all. So local anesthetic solutions with gargles, use of antiviral drugs like cyclovir, prescribed 400 milligram, TID for 3 or 4, maybe around 1 week, 7 days, and slowly shorten the duration of the drug. Depends on the severity of the lesion. And in many cases, if the hygiene is poor, you have to re-establish the oral hygiene status in a good condition. So you have to remove the causative, plaque, calculus, etc., etc. But extensive periodotherapy postponed till acute symptoms subside. You can give supportive treatments like copious fluid intake, systemic antibiotic therapy, aspirin for relief of pain, a dosage of roughly around 500 milligram of paracetamol 6th hourly or 8th hourly, depends on the malaise of the patient, to reduce the fever. Now, the another lesion which I explained before is, in the classification I explained, is pericornitis. It's again an acute stage of the disease. The name pericornitis means around the crown. So normally there will be an unerupted tooth, most probably a wisdom tooth. And this term refers to inflammation of the gingiva in relation to the crown of a uncompletely erupted teeth, which again acute, subacute, and chronic. Clinical features are, talking about the signs, gingiva appears red and swollen. Many must have experienced this lesion usually at the age of the 20s because the last wisdom tooth erupted at that age. So the gingiva appears swollen. Gingiva may be separative and tender, aggravated by trauma from the opposing tooth. Regional lymph node adenopathy is involved, most probably submandibular lymph nodes. And symptoms like fever, malaise, and bad taste because of the activity of infection there, severe pain, as because it's of a radiating solid pain, it radiates to ear, throat, and floor of the mouth, inability to close the jaw. There will be a partial or a fully trismus. Management. When you talk about management, there are a lot of risk factors. Presence of unerupted or partially erupted tooth usually has a communication in the oral cavity with a vertical or distangular mandibular third molar, most commonly affected. Usually call it as a impacted tooth. There must be a pathological periodontal pocket close associated with the infected tooth. So naturally there will be an additional infection of that. Opposite tooth in relation to the opposing tooth may interfere with occlusion, leading to ulceration of the mucosa around the pericorneal area, or a repeated pericorneal infection. Poor oral hygiene and respiratory tract infections are the risk factors. Now we are coming into the diagnostic criteria. Presence of unerupted or partially erupted tooth you can see in the radiograph, and cardinal signs and symptoms of inflammation associated with periodontal pericorneal tissue, local pain and discomfort, swelling, erythema, difficulty in opening the mouth, many times pus discharge, restricted mouth opening, abnormal taste, halitosis, cervical lymph adenopathy, and systemic signs of diseases like generalized malaise and fever, etc., etc. You can see. Treatment. First is irrigation of the pericorneal area, use of local agents to curate the soft tissue, removal of the opposing tooth if needed, use of appropriate analgesia and appropriate antibiotics, preferably penicillin group. Maybe if pus is involved, you can give metronidazole, and use of 0.12% of chlorhexidine frequently for gargle, and removal of the associated tooth. That is very important because that is a causative factor of pericornitis. So this is about the treatment line of the disease. If it is untreated, the complications are oropharyngeal, posteriorly may spread to the oropharyngeal area, medially the base of the tongue, making the patient more difficult to swallow, and finally end up in Ludwig's angina, maybe a space infection of submaxillary submandibular area. So considering all these complications, you have to treat it as early as possible. So I'm just coming to the end of the acute gingival diseases. Okay.